Hello, everybody. It is Monday. So, in the last, vlog entry in the last vlog, I had mentioned that I was going to be on Victoria Bowles AMA, Ask Me Anything live stream that was on Saturday. The overall, the interview went great. I thought it did. I was very impressed with the platform, which I did ask. It was StreamYard. So if anybody is interested in doing a live stream, you guys should check out StreamYard.com. The first time that I heard about StreamYard was through a YouTube channel called Think Media, and so they use it in their live streams to also, I guess, present live sessions with the PowerPoints and all of that. So let's talk about live stream. So I'm intrigued by it, by the live stream, but am I ready to do it? The answer is no. The reason why is because through the podcast, I've done many interviews, approaching again 100 episodes, interviews with people, versus doing a solo podcast episode. Solo podcast episodes are easy. You get on the microphone, you record it, you put it out. It's a little bit more involved when you have a guest, and you have a guest every week, or have a guest every 2 weeks and release every week. Now, to turn that into a live stream, it's a process, because you're not just considering the person who's doing the live stream. Like myself, if I were to do the live stream, I'm taken care of. I could handle all of that. But the challenge is in doing a live stream with another person is the consideration of the other person, their schedule, their time. What I do with my guests on my podcast is give them 3 questions. Because they normally ask, well, what's this podcast is all about? What's the topic? And I give them three questions. Where did you come from, and how did you get to where you are today? And then we go. Once we talk about that, I ask further questions about their job, career, and everything, their journey. And then we go into the last 2 questions, which is what does the future hold? And then the last one is what best words of advice. So if you're looking to do a podcast, those are the 3 major questions that you want to ask if you're interviewing somebody. Now, in my production, it's edited. There's a reason why it's edited, because if the guest makes a mistake, or if something is said that doesn't want to be released out in the public, I give full respect to the guest to let me know that. They need to tell me if that's information that needs to be shared out, because if that's sensitive information, I would not want to have that released. So editing to me is great on the podcast side. So that's the reason why I may not be ready to do a live stream. Now, if I were to do a live stream, there has to be a lot of back-end production to make sure that the guest is ready to be on live stream and willing to answer the questions that are being brought forth live in front of people. There was one question that was not asked in the live stream that I really prepared for. And here's the question that she gave me. So she has Victoria has a lot of LPNs and RNs in my audience, in her audience, Medical Coding, that are looking to making the move into medical coding and interested in CDI. Do you have any recommendations for nurses that are moving out of these hands-on clinical roles into something more administrative? And the answer is that if you're a nurse, LPN or RN, okay, you have the upper hand as somebody who understands the clinical processes, right? You know when they come into the ER, you know when they come onto your floor, you know what the protocol is. So you understand the clinical process, you understand how it's going to be documented, you know what questions to ask for certain conditions. But here's the thing that you need to do is take that clinical knowledge and apply it for documentation improvement purposes. But then you have another layer that you need to go through, which is the coding system. So if you're looking into getting into CDI, you need to understand and appreciate the coding system architecture, how it is set up, the classification system is set up. It's like walking into a building, okay, and you're given a blueprint of the full layout of the entire building. Do you know the ins and outs? Do you know where the exits are? Do you know where the bathrooms are? Do you know where the vital areas within the security of the building is? That's how you need to approach coding, is looking into how you can navigate through a system utilizing your knowledge in nursing and clinical care. Okay, so that's how that's how I wanted to answer that question. If I want to do a live stream, it may not be anytime soon. I think before I can even get into a live stream, I am going to, again, as mentioned in the last vlog, do interviews through video, which is going to be done on the Not Also Classified YouTube page. So that will be not live, that will be edited, okay? Because I like editing. I like to make sure that it's packaged right. I respect the guest. Nobody's getting in trouble. That's for sure. But to keep the conversation straightforward, that's another thing as well. So that's my take. A live stream, not now. Maybe in the future. So this morning, I woke up 6 a.m. and took my son to his football practice that starts at 7. Came home and decided to cook an early breakfast for my wife. She is an ER nurse and needs to come home to some food because by the time she gets home, she's wants to go to sleep. So this is what I cooked. This is garlic fried rice. Well, first let's start off with the main course. The main course is pork chops. Pork chops, salt. There's a seasoning called sazon that I add to this. And then from the pan, I immediately add maybe like a tablespoon of garlic. And whatever the oil and the butter that's in there, I add the rice. And add some salt and pepper. And then you have a quick garlic fried rice. So this is the breakfast of champions, especially for my wife, who is an ER night shift nurse. All right, everybody, is it Tuesday? Yeah, it's Tuesday. So I wanted to catch up on some of these coding cases that I've been doing. And these individual coding clips, as I have titled them, they are released on Instagram and also Facebook individually. And as I mentioned before, I also clump all of these coding clips together once a month and put them on YouTube. But you'll see them individually in the vlogs. So it gives you, I guess, an incentive to keep up on the videos that I put out. I do have a case today that I caught last week. It's a continuation of when I mentioned syncope. The last case was syncope. Patient had gastritis. Patient also had COVID-19 but left AMA. And that discussion was, what was the principal diagnosis? Now in this case, I'm trying to remember this. Okay, so the last thing I said, syncope should not be your principal diagnosis. If you have worked in CDI or interested in CDI, just note that symptoms as a principal diagnosis is something that you don't want to have, because you really want to find what that underlying condition is that's causing the symptom. So in my case, I have this patient who presented with a syncope. The patient was, I guess, when you look at the history of present illness, the patient stated that he got angry over some money dispute, started to have palpitations. And then when the patient had the palpitations, that's when the patient passed out. So the way the coder assigned the codes for this case was principal diagnosis syncope, secondary diagnosis sick sinus syndrome, which is a cardiac arrhythmia issue. When you look at this as an auditor, syncope principal diagnosis, automatically I'm thinking, well, what's causing that syncope? When you look down the list of diagnoses, you also see sick sinus syndrome. In the lines of this, of cardiac dysrhythmia, orthostatic hypotension, even atrial fibrillation, atrial flutter, ventricular fibrillation. You get my drift, right? When you look at the discharge summary, what's most important, what you need to look at is the hospital course. What did they do for the patient in this case? And so the hospital course was really cardiac driven when you look at the whole entire picture, right? So, of course, I believe that the sick sinus syndrome caused the syncope, and the syncope, which was mainly treated during the hospitalization, should have been the principal diagnosis. So, of course, I did my work, submitted something to say, hey, sick sinus syndrome should be the principal diagnosis. Now, here's the change. The syncope as a principal diagnosis is a higher relative weight compared to sick sinus syndrome as a principal diagnosis, meaning that it pays more to have principal diagnosis of syncope versus sick sinus syndrome as your principal diagnosis. So it doesn't look right. It looks like in my eyes that you're trying to make more money out of this case, even though the case wasn't treated as a syncope. The patient did present it, but after study, according to the definition of the principal diagnosis, the sick sinus syndrome is what was being treated, and as such should be your principal diagnosis. The change or the resequencing of the principal diagnosis results in a 35% decrease in relative weight. Be very careful with your symptoms as your principal diagnosis, because you want to make sure to find out what is the underlying cause, the definitive underlying diagnosis. All right. So I had to pick up my camera really fast because I am reading a query that is part of the medical record. Okay, so if you're trying to understand what clinical documentation integrity is, the query is a question that's being asked for the physician for clarification of documentation. Okay, in this case, based upon what I'm reading here, they're asking if sepsis was ruled in or if it was ruled out. All right, so I'm gonna kind of paraphrase because I don't want to read this verbatim, but it says in the query, "Dear doctor," okay, it notes an admission order that includes severe sepsis / septic shock. Okay, and the CDI specialist puts in these vitals, okay, which include a temperature 36.9, heart rate of 104, respiratory rate of 24, systolic blood pressure of 187, lactic acid of 4, white blood cell count 13.64. Okay. Patient was given antibiotics. The history and physical diagnosed the patient with acute gastroenteritis. The discharge summary discharged the diagnosis, put a discharge diagnosis with acute renal failure and dehydration with an admitting diagnosis of severe sepsis / septic shock. So I guess I'm I'm gonna guess that they are asking if sepsis was ruled in or ruled out. And so that's what it was. The question is, after study, was sepsis ruled in or ruled out? Now here's where the mistake came in. The mistake that I see is in the choices that was provided to the physician, which when you give choices for the physician, all they have to do is just mark it. In this case, they have to put an X. So here are the choices. Severe sepsis / septic shock was ruled in. Severe sepsis / severe sepsis / septic shock was ruled out. Clinically unable to determine, unknown, or other response. All right, cool. Now, the issue comes in with the septic shock, okay? Because when you think of sepsis, severe sepsis, septic shock, okay, sepsis is a systemic response to an infection, okay? Severe sepsis, by definition on the ICD-10 side, is if there is organ dysfunction, all right? I'm not going to get into sepsis criteria, but I'm just going to leave it based upon coding definitions. And septic shock is basically severe sepsis with hypotension, right? Hypotension. But when you read what the CDI provided as clinical indicators, the patient, the CDI provided a systolic blood pressure of 187. The question that I have is, did the patient present with hypotension? Because when you think of septic shock, the patient should have some type of volume loss resulting in some form of drop in blood pressure. SBP, systolic blood pressure of 187, is that hypotensive? Does that constitute a septic shock? Another question is, why, if you're asking if sepsis was ruled in or ruled out, why was septic shock included in the query to be ruled in or ruled out? That's something to think about. For those studying for CDI credentials, even coding credentials, even the HIT, the RHIT, and the RHIA exam questions have CDI in it. So this is something that you have to be very careful when you are asking the physician. Double check your choices, because physicians will be in a rush and they'll just go boop boop and just go along their day. So be very careful, be very clear in what you are asking the physician, and make sure that the choices are legit and clinically supported.
MedicalCodingGeek.com